Welcome to the Critical Care Obstetrics Podcast. I'm Dr. Stephanie Martin. I'm a maternal fetal medicine specialist and medical director at Clinical Concepts in Obstetrics. And I'm here with my partner, Suzanne Baird. Suzanne is the nursing director at Clinical Concepts in Obstetrics.
Hey, everybody.
And we've got a... Hey.
I'm pipe in now.
We've got a kind of a different topic that we're going to address today about what to do when a mom dies. Like, how do we approach this? And before we get into it, I first want to talk to you about a few things beyond the podcast. We are going to be also showing slides today. And so if you want to see the slides, you can find us on YouTube. Just search for the Critical Care Obstetrics Podcast and enjoy the podcast. Visually, you can listen to it, but we've got slides there if you want to follow us there. Don't forget about our CCOB Academy, where we've got a full library of online courses that we specifically designed to build confidence and skills in managing high-risk and critically ill obstetric patients. You can also join our community on Patreon at patreon.com/CCOB. Your support there really helps us continue our mission, and you'll get access to exclusive videos, opportunities to interact directly with us, and we do a lot more teaching pearls and deeper dives on topics. So connect with us anywhere and everywhere we're out there on our socials and Patreon and YouTube. So Suzanne, I thought we'd start by going over a case. And then at some point we'll both share experiences. Unfortunately, we've both had too many experiences with a loss of a mom or a near loss of a mom. So we've got our own personal perspectives on how to deal with this.
Yeah. And it's something that you never forget. And this is a kind of a lecture that we put together many years ago, a colleague of mine, Dr. Betsy Kennedy, and we presented this at A1 one year. And I tell you, we were all crying in the room, and people said, this is just not a topic that we normally talk about, that we need to talk more about because we really don't know what to do when this happens. So we'll start with a case, and then we'll talk about some of those things that we've learned in the process of supporting patients and families and staff through a maternal death. And so, because this is becoming all too frequent for many of you, and you've had an experience similar to the one I'm getting ready to present. So this was a 25-year-old gravid of 1. And the reason why age makes such a difference, I think, is we often think, oh, she's 25 years old. She's going to have a normal, healthy pregnancy and everything is going to go great. And she's normally healthy. But in this case, this patient had chronic hypertension. So she has a comorbidity entering in pregnancy. And as you know, in the many years we've been doing this, we've talked a lot about the increase in comorbidities in patients that we're seeing clinically these days and how that is influencing some of our severe maternal morbidity and mortality. And this patient was diagnosed with chronic hypertension during her prenatal care. So before 20 weeks, she was already hypertensive. And that plan changes when a patient enters in and they're getting the most care that they've ever get in their entire life. Right? They may or may not have even been going to the doctor every year for an annual exam at 25 years old, right? I don't think I did when I was 25. I don't think I went to the doctor every year just for a physical. I wasn't a pediatric patient anymore, so on and so forth. But in the first trimester, you see her range of blood pressure is 144 to 150 systolic, and diastolic ranged 80 to 90. So certainly that met the criteria for chronic hypertension. And this was on more than one occasion. This was pretty consistent. These are her ranges. Second trimester, see its range is a little bit wider, 124 to 160 systolic and 70 to 80 diastolic. And her meds, a little strange, but phenobarbital, I don't know why she was on that, but Aldimet's a very commonly used med. And then Vistaril, I guess that was
It was commonly used at the time of this
Yeah.
case.
Yeah.
It's less commonly used now, fortunately, because in
Thank
my
you.
opinion, it's one of the least effective medications, and it's very difficult to take. So,
Yeah.
now if a patient requires antihypertensive therapy, we would be recommending nifedipine or labetalol as by far the most common medications for those of you who are wondering about the use of methyl-dopa.
Yeah, absolutely. Okay. So here's her prenatal history. So at 33 weeks, she comes in with severe range pressures. Her blood pressure is 180 over 110. She has 1 plus proteinuria, and they send her home. At 34 weeks, she comes in. Her blood pressure is 190 over 200, systolic, over 120 to 130 diastolic, and 1 plus proteinuria. Sent her home. And then at 35 weeks, her blood pressure range is 196 to 200, over 120 to 130, with 1 plus proteinuria. And they sent her home again. There's
I
no
hope everybody's
document.
got hypertension. I hope everybody's blood pressure is going up listening to this.
I know. I know, right? So it's one of the things that we look back at, and looking at that prenatal history. And I've seen a lot of normalization of deviance with blood pressure ranges in chronic hypertensive patients. I know you have too, Stephanie.
Mhm.
And and people just say, "Yeah, that's normal for her." And truly, if she were in a non-pregnant state, they may run higher pressures, but certainly in a pregnant state, we would never want to send this patient home without sending her, number 1, to the hospital for evaluation and stabilization of her blood pressures and possible delivery, but also a more in-depth workup for superimposed preeclampsia, because we know that, 25 to even higher percentages in some studies show that those patients will go on and develop superimposed preeclampsia. So the other thing that was significant about this patient is that she was planning on delivering at a level 1 maternal care center. So the resources for this patient at that hospital, and this patient who has severe range blood pressures and possibly superimposed preeclampsia, they will not have those. They may or may not even have an in-house OB physician. So she makes it to 37 weeks, believe it or not, but she comes in. The reason that brought her in was chest pain, shortness of breath, heartburn, and headache. And all of that makes me short of breath, especially when I look at her vital signs, which are 97.9. Her heart rate's 108, so she has tachycardia. She's tachypnic at 32 breaths per minute, and her blood pressure is 179 over 110. And the nurse's note states, patient not in labor, so vag exam deferred to decrease patient anxiety. If
There's
you're
that word.
There's that word, anxiety, yeah. Yeah, this all gives me anxiety. The tachypnea and the blood pressure, the maternal heart rate, the chest pain, the shortness of breath. What does this patient have without even looking at anything else? Stephanie, what does she have?
Pick me.
Yeah, I'll pick you.
She's got pulmonary edema,
Absolutely.
and I wanna know an oxygen saturation.
Yeah, right. Right.
Yeah,
And
yeah.
also, it tells me with the nurse's note, the assumption being made is
Mhm.
that her heart rate, her chest pain, her shortness of breath, her headache, her respiratory, all of her vital signs are related to what? Anxiety.
Anxiety. It's a mental health problem,
Right.
and I want to acknowledge this patient probably was extremely anxious because she's can't breathe.
Can't breathe.
She's not perfusing because she's severely hypertensive. She can't breathe. She's going to feel short of breath. I mean, that's going to make you feel anxious, of course, but it's a symptom, not the problem.
Right. Right. The physician note states a 25-year-old white female who prefers the sitting position.
Red flag,
Ugh, yeah. Can't lay down.
especially if it's enough for the doctor to make a note on it.
Yeah. Very obvious, right?
Right. This is a patient who is likely refusing to lay back.
Yes. Or can't. She can't. She can't breathe.
Right. Exactly. And that's why they're commenting on it, because how many times am I going to write a note commenting on how the patient prefers to be in the bed?
Right.
So to me, that's a striking statement.
Right. She's the note continues and says, admitted to attempt bed rest for hypertension, but this is a very hyper and anxious patient, somewhat similar to panic attack type personality and symptoms. Yeah. So the plan is to do an oxytocin challenge test. Some people are probably like, "What is that?" To see her NST was non-reactive, so they were going to do a OCT, and they did. They started on pitocin, got the contractions going, and lo and behold, it's positive. And so they decide they're going to induce her labor. And I
So,
know,
for those who are not familiar with an oxytocin challenge test, it's basically inducing contractions either by nipple stimulation or oxytocin, either endogenous or exogenous oxytocin, to make her contract at least 3 times in a 10-minute period. And then you observe how frequent the late decelerations are or not. And if you've got late decelerations with more than 50% of the contractions, then it is a positive oxytocin challenge test. And basically, you're trying to determine, do we think it's reasonable to induce this patient? Will the fetus tolerate the labor process or not? So I don't think they're done as commonly now, but there was a point in time where we were doing these routinely.
right, and I still see it every once in a while that people are
Mm-hmm.
doing them. Maybe they get a NST, it's non-reactive. They do a BPP, and they really can't decide on what to do with the patient.
Mm-hmm.
This patient has indications to be delivered anyway. She's chronic
Mm-hmm.
hypertensive at 37 weeks. Deliver her. you
Yeah.
know?
Well, I guess the question is vaginal or cesarean. So that's kind of why they're trying to do this. And sometimes it's a spontaneous OCT. Like patients can
Yes,
contract on their own and you can see whether or not this fetus is going to tolerate labor.
right. So the assessments continue. Her respiratory status with that admission respiratory rate of 32, there were no more documented respiratory rates for 4 hours, which again is a very common thing that we see routinely in these case reviews. They did not use pulse oximetry because they stated in deposition that she was not in labor and didn't have an epidural, so she didn't need a pulse ox. They didn't routinely use those unless the patient had an epidural. And the patient had numerous complaints of chest pain, shortness of breath, and now she's coughing. And those were all documented by the nurse in the medical record and the doc. As far as her hypertension assessment with that initial severe range blood pressure, her blood pressure range now has been 163 to 192 over 110 to 129. She has generalized pitting edema that was documented, and she continues to be on her methyl dopa, 250 milligrams PO, Q6 hours.
Can I comment here?
Sure, I want you to.
Okay. For those of you who are perhaps less familiar with obstetrics patients, maybe you're in the ED or whatever, blood pressures of greater than 160 over 110 require urgent intervention. We want to get the blood pressures below that threshold, generally within an hour, but that doesn't mean you wait an hour. Methyl dopa is never used for acute management of severe hypertension. Period. End of sentence. This is in the past we would use it for chronic hypertension management, but it is not for acute severe hypertension. This patient needs labetalol, hydralazine, or nifedipine. Now, the guidelines for treatment of severe hypertension have not changed in recent years or in any time. I mean, this is a long-standing guideline. The nuances have changed. The access and ease of access to algorithms and more data supporting the recommendations has improved, but the guidelines are fairly similar. The edema is interesting and important, even though edema is not part of the diagnostic criteria for preeclampsia. It is a very important, crucial clinical clue. This patient has pulmonary edema. The question is, does she have cardiogenic or non-cardiogenic? The answer is probably both.
Yeah,
But
maybe.
at minimum, she's got very likely non-cardiogenic pulmonary edema, because the same swelling that you're seeing generalized, it's happening in the lungs. And the severe hypertension can be contributing to poor cardiac output, which can add a cardiogenic component on it, but we don't know that. But this is not just a hypertension problem. This is a big leaky vessel problem on top of everything else.
Right. And the thing about the clinical clue that it gives me as a nurse is I want to look at that generalized edema that she has, and I want to go back and look at her labs that we've
Mhm.
drawn. And I want to look at her serum albumin and look at her total protein values, which are going to
Mhm.
be extremely low. And
Yes.
that is a clinical clue as to what her intravascular colloid oncotic pressure is. And in this patient, I would bet my right arm that she would have an extremely low colloid oncotic pressure, and the ability to hold fluid in the blood vessels is going to be extremely low with a low
Mhm.
colloid oncotic pressure.
Right, and so if you give this patient IV fluids, you're just gonna pour more fluid into her 3rd spaces, into her lungs and her legs and her belly and all that stuff. It's not necessarily gonna stay intravascular.
At the same time, if you don't optimize her intravascular volume, her cardiac output drops,
Mhm.
and her blood pressure even could be compensatory at this point to try to maintain, squeezed back to the right side of the heart. It could be because she is hypovolemic,
Mhm.
and that once her intravascular volume corrected, that it may come down some, but we don't know. We don't have any any other
Yes.
data to go with, and which makes this patient a perfect candidate to have other testing like an echocardiogram.
The other thing is we've got this fetal monitoring, right? So this fetus is not getting perfused. We have 2 potential, like, top of the list explanations for this. One is volume depletion and shunting away from the uterus, decreased perfusion of the uterus by high pressures, low volume, shunting away from the uterus. And the second is this patient is likely hypoxemic and it's just not yet been documented. So you've got decreased oxygen saturations and decreased.
Well, and in this particular patient, she was talking. And but the assumption was this is a blood pressure problem.
Mhm.
That's it. A
Yeah.
chronic hypertension patient that just has a blood pressure problem, even though she's not perfusing the placenta and has a positive OCT. So her cardiovascular assessments continued to be very concerning. Her heart rate, she came in with a heart rate of 108. Well, it went up from there. And now her heart rate is at 135. And the patient describes it as it feels like my heart is beating real fast and then it hurts. And then I can't get my breath. And the physician note around the same time was the patient was complaining of chest pain. And although it seems to be related more to anxiety and panic attack than any other physiologic cause. And
Absurd.
well, just the lack of critical thinking, too, right? Because again,
Complete.
this patient could have both types of pulmonary edema. She could also have cardiovascular disease, where she's got chronic hypertension, but her heart is working so hard. She's even telling you how hard her heart is working
Mhm.
by saying
Mhm.
it's beating real fast and then it hurts. So they were inducing this patient, and she had the recurrent lates, and she had minimal variability, and she'd had minimal cervical change after 29 hours on oxytocin, and it was determined at that point, ta-da, she was frank breech.
Mm.
So
Yeah.
now they're going to take this patient back to do a C-section because she's breech, right? And here's her vital signs. So this is for all of our anesthesiology colleagues out there, CRNAs. This is your patient. You're getting ready to go to the OR in OB at a level 1 maternal care center. This is your patient. Vital signs are 188 over 112. Her heart rate is 117, and her respiratory rate is 34. And I got to tell you, the last time I checked, she couldn't lie down on the bed. So,
And no oxygen saturation.
yeah, no oxygen saturation to this point because she didn't have an epidural. So they do a primary C-section. They put an epidural in her in the OR. Apgars are 8 and 9. And I've got to tell you, babies are made out of rubber, right? So
This one
resilient.
is.
Yeah. Yeah. Went to the newborn nursery. Okay. While she was in the OR, here it goes though. She's in PACU and she's admitted there. And here's her blood pressure 102/49. Her heart rate is 113 and her respiratory rate is 24. Her pulse ox entering into PACU is 78%. And they started her on oxygen, 5 liters nasal cannula, and her pulse ox came up to 95%. What do you think?
I don't like it at all. I mean, I'm happy that they got her sats up, but we're ignoring glaring signs. So that decrease in blood pressure is anticipated when you have a volume depleted patient going back and having neuraxial anesthesia. Because what happens when you give neuraxial anesthesia is that you instantly and massively vasodilate. So it's going to automatically lower blood pressure. And in this patient, when the tank is empty because it's leaked all out into the lungs and her other tissues, and then lost blood on top of that because she had a C-section, well, her pressure is going to be lower. And her sats, I'm glad that she responded to the supplemental oxygen, but that doesn't mean that everything is okay. Just because her vital signs are, quote, better, this does not mean that the patient is better in this situation because they're just ignoring everything.
Well, the other thing too with their blood pressure is her renal perfusion is going to be so low with that pressure because her body is not used to having that low of a blood pressure. So the longer that you may feel more comfortable because her mean arterial pressure is better and the systolic and the diastolic are better, but those kidneys, they're not happy at all. And they're
that's
not
the
going to
same.
perfuse.
You're right. And that's the same thing that, like, say that this patient got an epidural in labor, okay? Not at the time of C-section. It's the same concept. So use the body, when you vasodilate like that, the body's gonna, and your volume depleted, the body is going to redirect blood to vital organs. Kidneys and uterus are not vital organs. What you're saying, Suzanne?
Right. That when in doubt, cut it out. Liver, heart, lungs, and brain, only these must remain. The
Yeah.
kidneys don't matter, right?
And neither does the uterus. They're not on that list. So they're going to stop getting blood flow. And that's why you get that epidural dump. Like all of a sudden,
Right.
10 minutes after the epidural, the heart rate goes in the tank, and now we're crashing C-section. It's the same concept.
Yeah. And the same thing with the lungs. We may have treated a symptom by starting the oxygen, but we've never dealt with the issue, and that is pulmonary edema. Nobody comes into the PACU with a SAT of 78. And I'm not comfortable at 5 liters nasal cannula. First off, that's a blow dryer blowing up your nostrils. And then at 95%, okay, it's still not a critical value, but is it going to stay that way? And the answer to that is going to be no. She's going to get into pain, and that's going to use more oxygen. You're going to move her around. That's going to move more oxygen. You're going to rub on her tummy and tighten up her uterus, and she's going to, flinch and clench her mouth. All of this consumption of oxygen in a patient that is teetering on the cliff, right?
And they're probably still running fluids in at 125, 150 an hour.
Or bolusing her to get her blood pressure up some.
And then
how
2.5 hours later, we're
Yeah.
shocked when she's now coughing and feeling worse.
Completely anticipatory. Completely. It's one of those cases where you're looking at it and you don't even want to turn the page because you know what's coming next. You know it's there. And now she's sitting up in the bed, again, complaining of shortness of breath. And now she's satting 79% pulse ox on that 5 liters nasal cannula. They switch her over to 10 liters face mask. And the patient turns over. They turn the patient, and her pulse ox plummets to 63%. Red flag, red flag, red flag. That is, the patient's off the cliff, right? So they call in the anesthesiologist. They give her some furosemide, 10 milligrams IV. They draw a blood gas, which comes back at 7.33. Her CO2 is 46. Her PO2 is 38. And her base excess is 2.2.
It's never good when you look at the ABG and you have to wonder which one's the CO2 and which one's the O2.
Yeah. Well, that and we're wondering if it's a cord gas.
Exactly.
It looks more like a fetal cord gas.
So for those of you who don't interpret ABGs all the time, the two things that you need to notice on this one is her pH is less than 7.4. This is bad. Pregnant women should, and even though she's postpartum, this is not enough time for it to go back to non-pregnant state. So 7.4 and above for a pH. And on oxygen, that PO2 should be in the many hundreds, not in the 30s. That tells you you're not getting oxygen across into the bloodstream effectively. And it's, the SATs of the 60s, now we're SATs in the mid 40s. Those aren't even real SATs. Like what it's telling you is she has no oxygen. And she's
Yeah.
ripping the face mask off. Like,
Yeah.
of course she is. She's suffocating, literally.
Yeah. They encouraged her to keep the mask on. So they gave her more Lasix, some for most of my at 40 this time.
Mm-hmm.
And now they've notified the ICU, and the plan is for intubation. The patient's breathing rapidly. Her lips are slightly cyanotic and her pale color of a skin, and she arrests. And they resuscitated her. She got ROSC. 10 minutes later, she was intubated and then transported to ICU.
So ask yourself, was this predictable, preventable?
Yes.
I hope everybody is screaming right now, going, yes, oh my gosh, yes.
Yeah.
That's what we hear from you guys.
Yeah. Yeah.
Yes, this is a predictable and preventable event.
Right. Then she
And
was
now we're calling for maternal transport.
Right. And I'm glad they did, but it's just so late, right?
Too little, too late.
Right. And everybody's like, well, I want to have my baby at that hospital. No, nobody wants to deliver there, right?
Mm-hmm.
And she gets transported to a tertiary care center, to an OB critical care unit. She has an ART line. She has a central line in place with hemodynamic monitoring that was placed in the ICU at the level 1 center. She had a cooling blanket on because her temp had jumped up to 103, and she was on the ventilator. Had appropriate settings, I will say, tidal volume of 800.
Peeps high.
And her PEEP's high is 15. So the outcome in this patient, she got the chest x-ray and diffuse severe air filling process with almost complete whiteout of both of her lungs. So acute respiratory distress syndrome. Therefore, she had non-cardiogenic pulmonary edema. The diagnosis was hypoxic encephalopathy, and she had brain death from anoxia. No evidence on MRI of cerebral blood flow, and life support was removed, and we had a maternal death. So we want to start a series on maternal mortality and how we support you, how we support the patient and family, and how we support each other in a discussion. And we wanted to introduce this series with a case study. And in our next episode for our podcast, we're going to do talk about kind of planning and how we respond once a mother dies. And then we're going to have another podcast on what we do to support the patient and family during, once a maternal death occurs. And then we're going to talk about the how to support each other. Because again, this is stuff that we don't normally talk about. And we know that maternal mortality statistics are so high right now. And we need to start discussing more on how we do this and what we can learn from each other. So we want to hear back from you on what you think would be beneficial to learn from each other in this process. And if you have any other ideas, send them our way on our website. You can reach out to us or any of our social media that we just discussed, and let us hear from you. Right now, our maternal mortality rate in the United States, in the latest data, We've come back down to where we were pre-COVID, but we're still really high. We're at 18.6 maternal deaths per 100,000 live births. And this is the data from the CDC and the maternal mortality in the United States. That equals 669 maternal deaths a year. Still
Think
very
of it
high.
as generally, on average in the US, about 700 women die
Yeah,
every year. It's been fairly consistent with the exception of the Delta wave of COVID in
right.
2021.
Right.
About 700, and that's just too many, and that far outpaces any other developed countries.
Right. And the most common causes are listed on this slide. And these are data from the maternal mortality review committees and in most of the states in the United States. And this data was published recently in 2022. And it was number one causes are mental health conditions, which included deaths from suicides, overdoses, poisoning related deaths due to substance use disorder was number one, and followed by hemorrhage and cardiac disease were neck and neck. And the others are pretty consistent too, depending upon what data set you look at, but infection and sepsis right there at the top, thrombotic embolism, cardiomyopathy, and then hypertensive disorders in pregnancy. I would say those have been the consistent pattern in all of the data sets, depending upon where you get your data.
And it used to be that the top 3 causes were hypertensive disorders, bleeding, and VTE. And then as a result, there were concerted efforts to standardize care, introduce checklists, processes, and have requirements that this all be addressed. And they dropped out of the top 3 spots for a significant amount of time. Hemorrhage has been pretty stubborn. But when those dropped out of the top, then others filled the void: cardiac, infection, sepsis, etc. The inclusion of mental health conditions, particularly suicide and substance use disorder, is a relatively new concept and a very important one, especially when we're talking about including deaths beyond the first 6-week period and into the first year postpartum.
Right. So, right now, I want everybody just kind of think about where you were, what you were doing when you've had a maternal death, either as your patient or a patient on the unit. And if you haven't had a maternal death, maybe it was an outcome that was not um, up to where you know, it was a bad outcome. You had severe maternal morbidity, severe hemorrhage, or something of that nature. But close your eyes and just kind of think about that. And I will tell you that having had n- numerous maternal deaths myself, that I remember patients' names. I remember what they look like. I remember where I was in the room. I remember what role I had. It has been the most, you know, memorable things in my career that I remember, and I can still call their names. And I think many of you will resonate with you as well. Stephanie, why don't you tell us about a maternal death that you might have been a part of?
Yeah, I have quite a few, unfortunately. And um, the one that I reference quite a bit was because it was on my first day as an attending. Literally my first time to take call as an attending. I was still in my fellowship, but we were, general OBGYNs, and we would take call and supervise the residents, et cetera. And this was a patient who presented. She was a young 20 or 21-year-old nulliparous patient, post-term, being induced because she was post-term, and was my only normal patient on the board. Everybody, I had taken countless transports that day, and everybody was very sick and very high risk, and she was the lowest risk one. And it was the middle of the night, and I get called to her room because we have changes in the fetal heart rate that need intervention. She's completely dilated, and oh, by the way, she's also hypotensive, and the anesthesiologist is dealing with that already in the room by the time I get in there. I check her, she's complete, and can't a few pushes, it's clear this baby is not coming. And we decide, and while I'm assessing her, she starts getting progressively more hypoxemic and filling a mask with frothy pink fluid. We decide to do forceps to try and get this baby delivered as quickly as possible. And as I'm placing the first blade of the forceps, she begins bleeding from the urethra. So at this point, it's pretty clear, even though there weren't standardized criteria at that time, it was pretty clear she was likely dealing with an amniotic fluid embolism, but she was still communicating. She was still conscious and responding to instructions, etc. And so we were unsuccessful delivering the baby by forceps. So we took her back to the operating room because it was clear that she needed to be intubated. And then we were going to deliver this baby once we'd intubated and stabilized mom. She moved herself to the operating room table and um, got intubated. Mom and baby both passed in the operating room. We were able to get her return to spontaneous circulation, get her to the intensive care unit, but she arrested. The baby could not be resuscitated, and she ultimately passed away shortly thereafter in the intensive care unit from an amniotic fluid embolism. And at the time, there was really no support for providers at all. I had been on a shift, all day, all night. It was now morning, and I had to document all the things that happened in this event and somehow see a few patients. And, I didn't get home until late in the day, by the time it was all said and done. People were kind and they were curious and they were supportive of my experience, but there was no acknowledgement uh, of anything that needed to be discussed. This was just, this happened. We're so sorry. How are you? Okay, you're on call in 2 days.
Yeah. Yeah.
My friends are what got me through. I seriously questioned my career in medicine at that point. I was like, I am not cut out to be a maternal fetal medicine specialist. This is not going to work if I can't, this happens literally on my first day. And they dragged me out of bed and made me live life because I was just reeling at that point.
Mm.
And 6 months later, had another one
Wow. Yeah.
down the hallway, same hospital, AFE.
Wow. Well, I want to tell you a story, and I don't think I've ever told you this, Stephanie, and um, I try to tell it without crying
Oh yeah, I'm
because
I'm 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 not. Before we did this podcast, I told myself you're not going to cry on the podcast. I've cried in
I
front
know.
of big groups of people when I tell these stories.
Yeah.
I think I've told the story enough times that I can stuff it, but it's I'm like hot. If you're looking on YouTube, I'm like having a hot flash right now because it's
I
so.
know. Well, and I'm trying not to cry because my eyes are full, but because it was one of the most beautiful experiences in my healthcare career at what I witnessed in the way that this patient was cared for. And she had come in and she had had a stroke and was declared brain dead. And she was on a ventilator, and her family lived out of town. And I remember this patient's name. I remember everything about it. And we had all taken care of her. And today was the day that her family was going to be able to get there from out of town. And the nurse bathed the patient and put her in regular clothes. And I remember her top was red. And I was in charge that day. And I came into the ICU. We had an OB ICU. And I came in, and the nurse was reading to the patient and talking to her, having a conversation with her, one way, obviously, but saying, "Hey, she was reading out of a magazine, a women's magazine or something, and it was like the colors this year are going to be greens. Greens are the hot color with plums. So when picking out your colors, thinking about those colors that would look good on you. I think that you would look good in plum. You're wearing red right now. That's, you have a really pretty top on." And she was just had provided the most beautiful care to this patient who was waiting for her family, and then we were going to remove her from the ventilator. And the family came, and she, they spent time with her, without, you know, a lot of us around or anything, and let them grieve with the patient and everything. And then we took her off the ventilator, the family being there during that time. And they looked at the nurse, and she was, of course, crying, and they were holding her hand, and the docs and everybody there together. The family prayed around the bed, and we took her off the ventilator, and she passed. But it was just this time that, again, in my career, one of the most beautiful ways in which I've seen a patient cared for. And honestly, we didn't know what to do. But the humanization of that experience for that family has just impacted my career. It impacted the way I would wanna be cared for. It would impact the way that I cared for patients in the future. Yeah, I mean, it was just one of those times. So, share with us what some of the experiences that you've had, and maybe we can learn from each other, in that. So, planning care for these patients, again, is something that we don't talk about often, and the how-tos, because, again, we don't do it very frequently, but having a
Fortunately.
thank goodness, but more than we like, and especially if you work in a tertiary care center, a lot of times these patients may be transferred in, and there may be nothing you can do to save them, or they could get worse when they're there because of, you know, their disease process or whatever, or lack of response to therapy or whatever, but you may have more than, let's say, a level 1 center. But hopefully, some of these things that we're gonna discuss, like the slide we're looking at now, is the decision making for end of life. And again, that's something that we don't usually talk about in OB, but advanced directives are critical, especially in planning. If you, let's say, work at a maternal fetal medicine office, or you are taking care of a patient who has extremely high risk critical conditions or the potential for that. But I hope that we see more and more of this being done, and looking at our advanced directives, like durable power of attorney and living wills, and do not resuscitate orders, or resuscitate in these ways orders, and thinking about our hospital policies that are associated with all of those. Because I think in the past, in OB, we've just kind of meant, yeah, 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 whatever, that doesn't really apply to us, right?
Well, I think, when in obstetrics, when we think about a maternal death, most of us think unpredictable, catastrophic, out of the blue type of event. That's not always the case.
Right.
And especially if you're on the receiving end of transfers, like Suzanne alluded to, you could be accepting a transfer of a patient who is brain dead after resuscitation, or who has hemorrhaged and they've done massive transfusion and they've resuscitated her, but she's not going to survive long term. Or perhaps she has a terminal illness and happens to be pregnant. There are a lot of different situations where the death can be anticipated, but certainly these are things that you have to know if they get admitted to an intensive care unit. And it's not things that we commonly think about. Patients may be asked about this when they get admitted. Do you have a power of attorney? Do you have a living will? But even patients aren't really thinking about this.
Right.
If these things don't exist, there are laws that dictate who makes decisions and how those things are done. And you, as the bedside nurse or the physician, don't have to know that immediately. There are resources within your facility who can help you. People who do this consistently, like our intensive care colleagues, tend to know the laws and know the route for this. So there is help if you are feeling a little bit overwhelmed. The DNR is very important because I think most of us assume that a pregnant woman, being young, would want full resuscitation, and that is likely going to be the case, but is not necessarily the case. But as I discovered when I worked in Texas briefly, at the time, I don't know if this is still the case, but at the time, pregnant women could not have a do not resuscitate order, that all pregnant women were considered full resuscitation. So sometimes this is patient's choice, and sometimes it's the law taking that decision out of the patient's hands, and it's this is how this will be handled. So you do have to know a little bit about what's going on, where you practice. And for those of you who are travel nurses, for example, it can be particularly tricky, but there are resources in your hospital that can help you.
Right. So, effective communication strategies are incredibly important during this time, for obvious reasons, but especially in planning, but also in, again, like Stephanie said, these can be either acute events, which is what we often think, or it could be, something that is planned or as a possibility, right?
Or
Or
anticipated.
anticipated, right? So it varies, and I've seen both.
And I have had conversations with patients. One patient in particular comes to mind that had severe pulmonary hypertension
Right.
and was pregnant, and very high mortality rates, even in the best care, with the best of care. And so we had to have conversations about her wishes should she deteriorate during the pregnancy, et cetera. So it maybe not something we do all the time, but we do need to be prepared for it.
Right.
But then
Same.
and then once someone has passed, I mean, I never got any training about what to say or what not to say. I learned this on the job, and then as my own personal growth and development, because of the situations I'd been put in, I started trying to learn more about how to handle these situations.
Right. Right. Me too. I know nobody ever talked to me about that. But one thing that we did learn was the grief and loss stages of grief. and and I know these have been discussed in various articles um and in clinical practice even, but a lot of times, depending upon where the patient is in this process, so if they had, let's say, as Stephanie brought up, pulmonary hypertension, I know I had a patient with aortic stenosis, severe values, and the stenosis. Um, we had these conversations early and
Mhm.
on what to do, and it clearly, even with that, you can see patients going through the grief cycle,
But
but
not just patients,
right, and the family,
the
yeah.
families and the caregivers.
Right, right.
Yeah.
So just important reminder of those stages of grief and to really our communication should be around which stage or where that patient is currently.
And if you've lost a patient, then you're going to be dealing with the denial and anger
Yeah,
stage,
yeah.
for the vast majority of you listening, because you're in that acute inpatient setting.
Right, right. So why it matters, because when we get it right with, our communication, and that's by showing empathy and providing good quality care, um, you know, bereaved people are feel more supported to accept the death, and I find that to be true, and to move into the, grieving process as a natural progression, versus if we get it wrong, then bereaved people may experience additional distress, and that distress will interfere with their successful transition through the grieving process, and implications for them and those around them and the larger community can occur. So, getting it right is so important. And that starts with good communication. And again, and where that patient is, or where that provider is, or where that family member is at that time is so important.
And this particularly applies, and we're going to kind of talk to a little bit to that, for maybe you have a patient who had a severe event but survived. She was in the intensive care unit. Maybe she was on a ventilator. Maybe she had an amniotic fluid embolism. Maybe she hemorrhaged. Whatever it was, she had some sort of birth trauma that was life threatening, or even not life threatening, just birth trauma. Handling this appropriately helps the patient and the family transition and process their grief.
Well, it
So there's
helps
things
me
to avoid
too.
saying. Yeah, absolutely.
It helps you as a clinician too, because you got it right, or you did your best to get it right.
Hmm. And I jokingly say a lot when we talk, that healthcare teams often mistake good bedside manner and caring a lot and working really hard for good care. You have to have both.
You have to have both.
You can't just have good care. You do need that caring a lot and working hard and empathy and all those things. It's important, but you got to have the good care too. We talk a lot about good care, but I think now we're kind of tying in the other stuff too.
Right. So, communication again, some of the things that we wrote on this slide, and if you're watching us on YouTube or if you're not watching us on YouTube, we have a slide that says things not to say pretty much and things you should say. So,
This could be a whole talk
there's going to be
right
a
here.
whole talk, right?
So we're just going to condense it into one slide.
Right, slide. But things not to say, like, it will be okay, or just focus on the new baby, or let me give you some advice, or you should have, or I know how you feel, or at least you have a healthy baby.
Mhm.
I think some of
And
those make us
I'm sure
cringe.
I'm sure I've said some of these things,
Yeah.
especially early in my career when I was young and, if you don't know, you don't know. I'm
Yeah,
sure I've said these things.
I think one that I could add to this is it was God's will,
Mm,
because you don't know that number one, you
mhm.
don't know their religious preference, but that's very touchy and thing I don't find comforting in my personal life. But to for someone to say that during a time when you've lost something.
If you don't know what to say, don't say anything.
I
Just be
agree.
present.
I agree. I think silence can be just a great form of communication as well.
Mhm.
So, some of the things that we just put on this slide again to talk about things you might want to consider saying is, I'm so sorry, or our team can help you with what is to come and the decisions to be made. And then another thing might be, what can we do to support you?
And it's just gonna depend on how close to the event you are, right? If something's just happened, if you've told a family that they've lost a mother, you're not gonna be asking what they need at that moment in time. They're gonna be acutely grieving. But very soon, you can ask specific questions. "Who can I call to be here with you? Is there, someone in particular you would like me to reach out to? Can I share this news with on your behalf? What can I do?" Truly. And then, yeah, but you don't have to say anything. You really
Right.
don't.
Yeah. One of the great books that I have on the screen right now is a book by Stephanie Arnold. It's called 37 Seconds. And Stephanie presented at A1 several years back. She is an AFE survivor, and she tells the story about when she died for 37 seconds, that she experienced what was going on in the room, and that she could hear the conversations that were being had. So in all of this, I just wanted to point out, don't forget to communicate with the patient at the center of the care.
Mhm.
Tell her what is going on and what you're doing and who is there and how you're supporting her, because we truly don't know what a patient may be hearing and what they don't hear.
I had a patient one time, who had hemorrhaged, and, I wasn't actually in on the original hemorrhage management, but she did, arrest, got resuscitated, ultimately survived, and after the fact told us that she was, like, hovering at the top of the at the top of the operating room, looking down on everything that was happening,
Wow.
and could tell everyone what had taken place in the operating room. Very creepy. Lots of stories like that out there. So I
Yeah.
think it's just, acknowledging that we have a human being. Of course, first you've got to save her life and you've got to do all the medical things that you have to do. But just that acknowledgement that there is a human there
Right.
that you can communicate with um and may be registering what you're saying. We don't know.
Right. Just a little bit on end of life bereavement care for maternal death. And again, I've experienced this several times with patients. That gave you the example of the one that in the previous story that I had. But some of the things to consider is palliative care and hospice care. So, just the differences. And we get that asked, what is palliative care versus hospice care? But palliative care is care for quality of life. Um, it may be somewhat curative treatment, like for especially to treat symptoms, but it is mainly symptom relief. And then hospice care is care for comfort and quality approaching the end of life. And that's, again, depending upon where you work, in what, uh, clinical setting, one or these may come into effect. I definitely think it's appropriate to um, have those conversations. Again, what is the patient's desire for continued life? And again, this is something we don't normally talk about in OB, but there are plenty of hospital resources to bring in to discuss those possibilities. Remember that we're mainly focusing in these two end of life approaches is to symptom management, and that is with pain, agitation, and dyspnea. So, again, there are great protocols out there for end of life care addressing all three of these with different medications, different modalities. And these three are the most important things. But we've got decision making and end of life care planning. We also want a quiet setting, a calm setting. We want to be sitting down with the patient and family. We want to watch our terminology, make sure that we are not using all medical terms that they don't understand. We want to give them as much time as they need. We want to show empathy. We want to actively listen. We want to have any cultural considerations included in that conversation and planning. Respect, showing respect for the patient's wishes, the family wishes. There's the hospital policies that we have to be aware of that we have to follow and to consider, unless there's something outside those policies, and then that would be discussed. Consents, knowing our resources. And again, in OB, we're not aware of those a lot of times, but we can become aware of those. And again, ahead of time is best. We want to provide privacy and then presence. Again, we talked about being present earlier and providing that empathetic support for the patient and family. Maintaining patient and family centered care is so important. Family visitation is encouraged as much as the patient and family want. So again, as you as a provider, you can be the gatekeeper as to who comes in and in the best wishes of the patient and the family. Patient family, the family presence during resuscitation is so key, and it's something that we encourage. There's been multitudes studies showing that when family is able to stay there during resuscitation, that they have less incidence of PTSD. Their stress levels of the healthcare team is a little bit of a mixed result bag in the research, because sometimes some healthcare providers that may stress them out more. But with the family perspective, I think it's important to say, get over it. Honestly, get over it. Your frustration versus the less PTSD and stress of the family, I think is important
I
because
think
other
the
studies. Uh-huh.
yeah, I think the frustration for many, not all, but it comes from when the family is not appropriately supervised and communicated with. So that then the providers feel the responsibility of both caring for the patient and managing the family presence. So making sure that someone is owning that family and communicating with that family is absolutely crucial.
Yeah, it's actually a role that we
Yes.
encourage for someone to have to be with the
Mhm.
family member to also tell them what's going on. This is what's going on. Um, and this is why we're doing things or whatever. And then if the family wants to move out, then that person can be assigned to taking them out of the room. But I remember, Stephanie, you and I were on a code together, and a family member wanted to stay. And She did. It was the mother of the patient, and she stayed with the patient until she didn't wanna stay with the patient. So that role was already assigned, and that person took the mother out of the room. So but it was
Mm-hmm.
her choice, right?
Mm-hmm. Right.
Research has shown that the effectiveness of resuscitation efforts are not affected by the family being in the room. So that is good. And there's no increase in medical legal damage claims based upon the family staying in the room for resuscitation. And I've had a friend that happened with her daughter, and she stayed while her daughter was resuscitated, and they allowed it, and it was encouraged. And she said it meant so much to her to be there. So I want you to think about that.
So, and then as we wrap up our conversation on this, let's talk just a little bit about postmortem care. Like what happens after the patient has passed, and now we have the practicalities of dealing with the situation. First and foremost, we want to make sure that we're preserving the dignity of the patient. And that means that you're going to have to be talking with the family about what their preferences, what their desires are, any cultural considerations, et cetera. There are going to be policies that guide what you can and can't do. For example, if you can bathe the patient, if you can remove IVs, if you can remove the endotracheal tube if she's intubated. Those are going to be dictated by what the actual situation is and what their policies and potentially even the laws in the region are. So there are resources in your facility to help you with those decisions, but always preserving the dignity of the patient. The family deserves time with their loved one, and you will allow for that. And again, if you're not sure how that works, you've got support in your institution to help you figure that out. The family should be allowed to have some privacy to grieve. Talk about keepsakes. Again, with a newborn passing or a stillborn, those processes are fairly hardwired in labor and delivery, and the nurses and the staff are going to be pretty familiar about what to do. You probably have a team whose this is their job, taking photos, locks of hair, footprints, et cetera, those kind of things. But with the adult patient, we don't necessarily know that, but those are things that can be considered. And then the patient's going to have to be transported somewhere to the morgue for autopsy, whatever it may be. Then she's going to have to be transported, and you're going to be facilitating that. Not the time to get into all the excruciating details here, but just some considerations to keep in mind. And if this is an area of interest of yours, or if you are worried about what would happen if you have a patient that is lost, then you can explore where are the guidelines and policies on my unit? How do I find out what happens when a mom dies in our facility?
Right. It
And
would be a
then
beautiful project, for someone to have these resources um, researched and available for if and when that occurs.
mhm. Now we're going to have a part 2 here. So we're going to have a part 2 with talking about more about the practicalities and what to look for, and just really expanding this whole exploration of maternal mortality, because we've got a unique perspective on it. I think we also have unique experience with having dealt with it many, many times over our very long careers. I mean, I've got many more stories that I could tell about the loss of a patient. Um, but we're just kind of dipping our toes into it here. But we really want to hear your stories. We want to hear your experiences and share your feedback if this is even a topic that interests you guys that you want to know more about.
Well, and we're going to delve into autopsy, which is a hot topic in maternal
Hmm.
mortality in the United States. It's not required, and some of those aspects of that.
So thanks for listening, everybody. Don't forget, check us out at the Critical Care OB Academy. Our website is clinicalconceptsinob.com. We really appreciate your support of our mission at Patreon, patreon.com/CCOB. And if you want to watch today's podcast, you can find us on YouTube. Just Google or just search for the Critical Care Obstetrics podcast, and then follow us on all of our social media channels. Thanks for your support.